The broadcast is now starting. All attendees are in listen-only mode.
Well, that was Sam and Dave. They originally did that song, and I think the Blues Brothers made it even a little bit better. So today, all of the music, all 5 pieces of music, introduction, 3 for the break, and 1 at the end, will be by different people, and it'll be a good old-fashioned classic rock and roll, which I love, which also may have been popular before you guys were born. Today is almost the last day of December. It's the 30th of 2021. The next webinar in 5 days will be in 2022, next Tuesday. And I want to say a couple words about today's topic, okay? We just finished a big 4-webinar topic on respiratory tract diseases. And now we're going to get into something called genitourinary, which includes both female and male genital systems, as well as both the upper and lower urinary system, as well as breasts. So there's going to be a lot of stuff. Actually, we're going to be doing 11 webinars. We've never did 11 webinars on one topic. Probably we haven't even done half as many, but this is going to be a long topic, and it's going to be probably extend all the way into February. And I'll tell you, it's going to be interesting. Today, we're going to start out with the urinary part of genitourinary, and we have both the upper, which is kidney, and the lower, which is ureters and bladder. And we'll be spending the first webinar and the second one on the upper, which is kidney. So today, we're going to talk about kidney diseases, and particularly some of the congenital diseases, some of the cystic diseases, and of course, the big topic of the glomerular diseases, or glomerulopathies, or glomerulonephropathies. I don't know if you could see this little warning sign over here, which I made, but it says warning, because I wanted to tell you that, every year I try to simplify some of the topics. Probably the one topic that's been the most difficult to simplify has been the topic of the glomerulopathies, okay? There's a few of them, and you might be confused. There are things that they share in common, but I tried very hard last night, like I do every year, to modify it a little bit so it's a little bit more understandable. Probably the glomerulopathies are the most difficult concept to understand in terms of how to differentiate the various types and what they're associated with. So let's give it a try, and let's start with our big 11 webinar series on genitourinary. Okay, well, there's the upper parts of the urinary. We'll talk about kidney today. And what do you see here? Well, what you see here are the three things that almost all of the classical renal pathology textbooks focus in on as three main parts, or three main sections, or three main chapters. They usually start out with the glomerular diseases, or the glomerulopathies. They then go into a little bit lower down, the tubular diseases and various things that could happen to them. And finally, the vascular diseases. So in that one picture, which I think you probably recognize as kidney instantly, because there's nothing else that looks like a glomerulus, especially when they're surrounded by these tubules. I think that you know that we're going to be taking a big bite into kidney today. And specifically, we'll say a few words at the beginning about the salient features of normal. I know you may have spent a lot of time learning the different cells of the juxtaglomerular apparatus and stuff like that, but we're going to do a big, quick, swift review of basic anatomy, histology, and physiology. We'll talk about 4 or 5 common congenital diseases of the kidney. And of course, the lower urinary tract is loaded with congenital malformations. The upper one doesn't have as many, but I've heard many of the really profound people, the urinary guys, the nephrologists, the OB guys even, saying that the lower urinary tract is probably the most common site for minor congenital anomalies. You probably all know people that might have had one. We'll talk about the various cysts in the kidney. I know when you dissected the kidney last year, it was probably very difficult to find one in your entire anatomy lab that didn't have some type of cyst. So we'll be talking about the differential diagnostic of the cystic diseases. And finally, the big topic for today, the majority of the topic, will be on glomerular diseases. That's webinar December 30th. On webinar January 4th, we'll deal with all the rest of them. So this is probably the single biggest topic. And once again, I want to warn you that it could be complex. I try to decaffeinate this topic year by year, and sometimes I think I make a little progress, but I think you're going to really have to focus in and pay attention, and maybe even memorize a little bit, okay? Well, here's a good place to start the development of the urinary tract, upper and lower. If you remember from your embryology, there were 3 parts of the development of the urinary tract. There's the pronephros, which is not really active at all in humans. It kind of degenerates. It's segmental. I think in some fish still might have it. Then there's the mesonephros, which gives rise to a lot of the male genital things, including, the so-called Wolffian duct, of which many of the male genital things. And then you have the mesonephric duct, which is the ureter, okay? And then finally, in the metanephros, first we develop pro, and then meso, and then meta. You finally have the kidney, okay? So that's the embryologic origins. And if you had dissected the kidney last year and you cut through it and you're lucky enough to see a nice smooth surface. Maybe the capsule peeled away very easily from the cortex surface of the kidney. If it didn't, that means there may have been some scars, which means cortical or perhaps even glomerular disease, terminating in fibrosis. Finally, we saw a nice, hopefully nice, normal, uniform cortex, which is basically this distance from here to here, from the arcuate arteries to the actual capsule. Okay, and sometimes the cortical substance, including glomeruli, extends between these pyramids. And these are pyramids because they all look like they're shaped like a triangle. And you might remember that if you dissected from the ureter, you had a big space. You had the minor calyces emptying into the tip of the pyramid, the major calyces, and the various arteries and everything. And why should I even talk about this? I hope you kind of remember it. And if you don't, here's a quick little reference over here. That's the renal vein. That's the renal artery. Okay? That you could call this a calyx. Okay? If it was an opening of some minor calyces, you could call it a major calyx. That the medulla is basically occupied by these pyramids. Okay, and then along the base of the pyramid is cortical. It should be probably about a centimeter, not much more than that. It should be uniform, and that's where the glomeruli are, but they do extend between the pyramids, which is called the renal columns. Okay, the major branches of the renal artery correspond to the main segments of the kidney. And classically, there is about 5, but that's not a hardcore number. There could be 6 or 7, but the segmental arteries are the first main branches of the renal artery. So, for example, perhaps a thrombus in one of the segmental arteries would block out about maybe 1/5 of the kidney. And because these are end arteries, they don't have a secondary blood supply. A blockage of one of the segmental arteries would produce a nice, more or less triangular infarct that is not hemorrhagic, but what they would call anemic. After the segmental arteries, you would think you would then have the interlobar arteries, okay, which I think you could see is probably one of these guys. And wouldn't it be logical that the interlobar would be bigger than the interlobular, because these are between the lobes and these are between the lobules. But in between that, there is an artery that runs pretty much along the junction between the cortex and medulla, called the arcuate artery. Why? Because it arches. That's why. Okay? And then, of course, the interlobulars follow that. Ultimately, they lead into the arterioles that supply the glomeruli. Okay, and of course with the segmental arteries, you have segmental veins. We talked about the renal columns. The renal papillae is the very, very tip of the pyramid, and that opens up into the minor calyx. And once you get into the tip of it and you are into the minor calyx, major calyx, you are now into a transitional lined or urothelial lined tubule, which extends all the way to the bladder. How do you like that? So technically, the collecting system, or you could say the beginning of the lower respiratory tract, starts with the minor calyces, and you can also say it's lined entirely by transitional epithelium, which is probably more often called urothelium now. And by the way, we'll talk about this later, but do you notice how if you were looking at the ureter, there's kind of a, not an abrupt turn, but basically it goes straight inferiorly, but it kind of turns here. Well, that's the most likely place for it to kink as well. So that's one of the 3 areas of the ureter which are most likely to get some type of obstruction. So here we go. We have the glomeruli. we have the tubules, and we have various blood vessels. Okay, this happens to be a good size artery. It could be an arcuate artery, I'm not sure. It looks like it's pretty big. Okay, and these are the three main things that we'll be talking about today's webinar and next Tuesday's webinar. So here's the real business end, however. You know that all of the action and all the excitement is at the level of the glomerulus. And the glomerulus is just a ball, a tuft of squiggly vessels, capillaries, so to speak. And they surround, or they are surrounded by epithelial cells called the podocytes. And the reason why they're called podocytes is because they have these little feet. Okay, that's the podo part. And the feet are up right against the basement membrane, and then on the other side of the basement membrane are the blood vessels. So if you wanted to memorize something visually from this transmission electron micrograph over here, think of the podocytes. You could think of that as the visceral epithelium. You could think of the epithelium comprising the Bowman's capsule, the parietal epithelium, and then you have this basement membrane, which among other things has a major component of type 4 collagen, and then you have the lumen of your capillary. And look, these tiny little things are the cytoplasm of the endothelial cells, but look, it's not continuous. It has these little interruptions, these little clefts. They are called fenestrations. So this is a fenestrated capillary. But the most important thing I want you to remember about this picture, because we're going to be getting into the glomerulonephropathies pretty soon, is that it's uniform in thickness and it's uniform in density. Okay, in almost all of the common glomerular diseases, the problem is in the area of the basement membrane or the things which touch it, which are the foot processes of the podocytes and the capillaries on the other side. So here's the big picture, here's a blow-up picture, and here's a scanning electron micrograph, which is probably the best one that I've ever seen. Okay, so if you wanted to think of it as diagrammatically, and you cut through the glomerulus like this, all of these red things would be your capillaries. Occupying the central portion of the glomerulus are the cells called mesangial cells, and mesangial cells regulate the blood flow of these vessels into the glomerulus, but they also have an immune function because they're capable of phagocytosis. So you could probably think of them as macrophages. I don't know if they're derived from the macrophage line, but let's review the few basic types of cells. You have your parietal epithelium, which comprises the Bowman capsule. Underneath that, you have your various capillaries. Okay. After the capillaries, you have your basement membrane, which should be thin and uniform in density and in thickness. Okay. And then you have your foot processes of the, what you might call the parietal epithelium, also called podocytes, because they have these little feet. Okay. That's another thing you might kind of remember as being a normal glomerulus. Okay, so much for the basic anatomy or histology. Let's get into something that many of your patients will have, and a disease which could happen to just about any of the diseases we talk about with kidneys. Kidney failure, chronic renal failure. What are the symptoms? Well, because your kidneys regulate water and electrolytes, you could have either dehydration or edema depending on the type of kidney disease. And of course, as your BUN and creatinine rise in your blood, so does your potassium. Another thing to remember is that whereas your potassium rises in the blood in chronic renal failure, the calcium actually gets low, okay? And because it's low, it kicks in the hyperparathyroids to compensate, and now you can have a disease, a general disease of the bone due to hypercalcemia called renal osteodystrophy. As your calcium gets low in general, your phosphate gets high. Okay, this whole picture would produce a scenario which would be an acidosis, okay, in your blood. And of course, it's not respiratory cause, so it's the metabolic acidosis. Why would a person with renal failure be anemic, other than it's probably the anemia of chronic disease? Well, one reason is you might remember where EPO is produced, okay? It's produced in the kidney. So you got kidney disease, you got less EPO. Another reason for anemia is that the toxins that build up in your blood greatly interfere with platelet function, and therefore the platelets don't work. In other words, you could have spontaneous bleeding with chronic renal failure, okay? You could have an inability or a great delay in your blood clotting as well. Any disease to the kidney which results in decreased perfusion could kick in the RAAS system, retain sodium, cause hypertension, be either a cause or an effect of congestive heart failure, because in congestive heart failure you have decreased flow to the kidney, but also chronic renal failure itself can complicate congestive heart failure. Okay, could you have pulmonary edema? Yes, you could, but that would be mostly due to the congestive heart failure. Patients with chronic renal failure, if you want to explain it in simple terms, because of toxicity to the mesothelial lined cavities, and in particular the pericardium, can get pericarditis. One of the most common cause of a significant pericarditis is chronic renal failure. When you do an autopsy of a person with chronic renal failure, the lining, both the visceral and parietal pericardium, could be very hemorrhagic and fibrinous and even contain pus. Okay, a condition often described commonly and in the textbook as bread and butter pericarditis. Because of the general toxins, you can have gastritis, you could have colitis to the GI epithelium, esophagitis. Look, that's the entire GI tract, isn't it? We already talked about the bleeding, but also nausea and vomiting, toxic effects on nerve and muscle and brain, okay, myopathy, peripheral neuropathy, encephalopathy, pruritus, okay, irritation, toxic effects to the skin, itching, dermatitis. And there's one word I want to concentrate on. You might think it's stupid, but I don't know if you've ever heard of the word sallow. Actually, sallow is a color. It's based on a plant that has a greenish yellow color to it. And the name of that plant is Salix caprea, and that's why it's called sallow. I don't know what kind of plant this is, but do you see that greenish yellow color? A person, particularly a white person with chronic renal failure, may have kind of a yellowish green. If you wanted to specifically label that color in terms of its RGB contributions, 214, 209, 177, for those of you people who can think of colors as combinations of red, green, and blue, this is how many units of each. There's the hex code for sallow. And if you like to just think of it in terms of a percent, sallow is 67% red, 78% green. That's the yellowish part. And a little bit of blue in there too, isn't it? So that's sallow. And if you have seen chronic renal failure people, they might not notice it, but you would say their skin is a little more yellowish, but they're not really jaundiced, okay? So let's talk about the congenital diseases of the kidney first. There's a few of them. You could probably say that wouldn't it be possible if people are just born without kidneys? They never develop? Yeah, that's called agenesis. And of course, as you would guess, it's incompatible with life. Agenesis could be either bilateral or unilateral. If there was only agenesis of one kidney, it is not incompatible with life. In fact, they could probably even lead normal lives, like they donated one kidney before they were even born. And of course, if one kidney does not develop at all or is donated as an adult even, the other side would probably be bigger than normal, or what they call compensatory hypertrophy. Could you have people that are born with small kidneys, either bilaterally or unilaterally? I think it's more common to be unilateral, but yes, that's possible. But remember, even if a kidney was not present at all, a good functioning contralateral kidney is not only life-saving, but might result in a normal life as well. What about kidneys that are not in the right position, okay? If you remember, the kidney kind of develops caudally, okay, but it kind of migrates cranially. So a congenital anomaly might be a kidney that has not migrated to its more caudal or superior position, which means it's probably going to be in the range of the pelvis. So an ectopic kidney, a kidney that has not been in its proper position congenitally, is usually also called a pelvic kidney. Okay, most ectopic kidneys, maybe all of them, are maybe called pelvic kidneys as well. What if the kidneys, for some reason, fuse in their inferior poles or caudally? They might look like a horseshoe then. It's like one big kidney. And yes, those are not uncommon either, and they're not and they are compatible with life, and there might not even be no emergency reason to separate them, okay? Well, here's agenesis. We got an embryo or a newborn that's opened up. Look at, folks, no kidney. You can see some loops of bowel, okay? This is probably why the embryo or baby was never born. Okay, if the baby had one kidney, it could have maybe even a good life, a normal life. Here's a kidney that is hardly developed at all. You could call it hypoplasia. Would extreme hypoplasia perhaps be called agenesis? Probably, but here's a little bit of tissue left. Whether it functions or not doesn't matter, but the more likely it is not to function, the more compensatory hypertrophy you might have in the contralateral normal kidney. Okay? And here's a pelvic kidney. Kidney here in a normal position, right where they should be at the level of the renal arteries. But this pelvic kidney you actually have at the bifurcation of the aorta, getting its blood supply. And by that time, you're already down into the pelvis, aren't you? Okay, so you might see on a bone scan, for example, which collects a urine, okay, is excreted in the urine, the bone scanning agent. You might have a nice bright dot here for the renal pelvis on the left side, but nothing on the right except for darkness there in the kidney. And it looks like that kidney might even be retaining fluid as well. Here's a nice contrast x-ray. You could see the 5 major calyces here. This segment this kidney had a 5-segment calyx structure, but on here, it's near the actual bladder, isn't it? The normal one would be higher up. Okay, so now you got a kidney that's just about on top of the bladder, and certainly in the pelvis anyway. Horseshoe kidney. Okay, well, if you just looked at the top half of this x-ray here, this IVP, you could see a good amount of, by IVP I mean intravenous pyelogram, a dye given in the blood which concentrates quickly in the kidneys and then gets excreted, okay? You could see a nice array of renal calyces on the left and on the right. It looks like it's pretty normal. And you could see some of that material might even extend a little bit inferior. But in this case, we have the 2 kidneys that are actually joined. And if you look at this little soft tissue density here surrounding the pelvis, you can see it extends inferiorly, which of course it shouldn't. Now, I think what you could say from this x-ray, if this was the kidney from it, that you don't have much of a collecting system in the inferior connection of the 2 kidney tissues or cortices, okay? So that's a horseshoe kidney. It looks like a horseshoe. Could this be asymptomatic and normal? The patient never knows they have it, no obstruction, perhaps discovered incidentally at autopsy? Yes, that's possible, okay? Okay, now let me make a statement. I'm assuming, because this is a second-year level course, I'm assuming that most of the people here have already a good foundation in anatomy. And part of a good foundation in anatomy in medical schools is to dissect cadavers. Now, some of the medical schools are getting these phony cadavers, which are computer things. I don't really believe in that. I think if you are a real doctor and a real surgeon, you have to get a good feel for dissection, okay? And of course, if you're a pathologist, you've already dissected 1 million, okay? It's not very often that you could dissect a cadaver, especially of an elderly person, which most of them are in medical school, maybe even elderly people with diseases, and not have some type of cyst. I can remember roaming around through the various autopsy tables for the first-year students and really having a very difficult time finding kidneys that didn't have at least some little cyst somewhere. So there is a whole big differential diagnostic of cystic diseases of the kidney. The actual most common congenital one is a condition called cystic renal dysplasia. And do not be fooled by the word dysplasia. It by no means means pre-malignant. It means there was a problem, an arrested problem in its development. So these babies could be born with extremely cystic kidneys, bilaterally even, and that would cause a very, very big problem. If the kidneys were not functioning, of course, bilaterally it would be incompatible with life. I think that's pretty logical. There's an adult condition, or at least it appears clinically in adult life, so that's why it's called adults, an autosomal dominant condition of cystic disease in adults, okay? And there is a autosomal recessive variant of genetic cystic diseases in children. Like most of the autosomal recessive diseases are apparent early in life, okay, children. Many of the autosomal dominants are not expressed until later on in life. You could have a condition where there are numerous small, tiny little cysts in the medulla of the kidney, the pyramids. And that's why it's called medullary sponge kidney, or MSK is what the radiologists like to call them. And another condition in which you have cysts at the cortical medullary junction, and that's called, I always have problem when you have 4 consonants or 5 consonants in a row. Nephronophthystis medullary kidney, also a genetic disease. You could have acquired adult cysts for various reasons, but probably the most common overall type of cyst is something that we just call a simple cyst. And the explanation that I have always been given for the simple cysts are very logical. If you have a kidney which is involved with draining fluid, and for some reason one of those draining tubes, at the medullary or higher levels even, are compressed, you would have a cystic buildup of fluid prior to the obstruction. So that's the general explanation for simple cysts, which are the kinds that I'm sure you have already seen if you've already dissected cadavers. Okay, here's the so-called renal dysplasia. The kidneys are enlarged and cystic. It could be unilateral or bilateral. If it's bilateral, we got big troubles. It's possible the baby was never born. Basically, it's just filled with cysts. You don't have to go into the types of epithelium surrounding them. But the reason that this kidney never really developed fully is that it still has this sort of primitive mesenchyme occupying much of the cyst, which has not really fully developed into cortical or medullary tissue. Okay, it's of course in newborns. It could be associated with viral diseases, or it could be genetic. It's more likely to be due to viral infection rather than genetic. But the people who have studied the genetic aspects of this disease actually found a couple of genes. I have them down here. I hope I can make them bold and underlined for you to see them. There's a couple of genes they have called the EYA1 gene or the SIX1 gene, and these are the genes which, when are mutated or absent, might give rise to a newborn cystic renal dysplasia. Now, in the adult variant of cystic disease, and remember, it doesn't mean that adults get this. It means that they probably have it for a long time, perhaps even as kids, but they don't develop renal failure type symptoms until their 40s and 50s or even later, okay? Now, it's an autosomal dominant disease. The 2 genes which are basically involved or mutated, and I think they're appropriately labeled, are PKD for polycystic kidney disease 1 and PKD2 for polycystic kidney disease. Autosomal dominant, it follows an autosomal dominant pedigree, okay, which means it probably does not skip generations, and it appears later in life, are the 2 factors of an autosomal dominant pedigree. It has a very complex genetics, but nevertheless, these are a couple of genes that are frequently indicted with the autosomal dominant polycystic disease. And clinically, these diseases can be very cystic, but they can still function, but they don't usually function throughout a normal lifespan. And I've known people that have had this, and they're terrified that maybe their kids have it too, because by the time they have renal failure, they might have had already a couple of kids. How do you like that? I think it's also more common in males than females, but remember, it's autosomal dominant. It's not sex linked. Okay, what about the autosomal recessive now? The autosomal recessive may skip generations, but remember, you need 2 defective alleles. But when they do get together, it appears early in life, okay? And if you look at the kidneys, it looks exactly like the adult variant, but they're now in small kids. And rather than be called PKD1, they call it PKHD1, okay? A gene similar to the gene that we saw in the autosomal dominant. The autosomal recessive, technically, it's a different gene. Now, if you survive this as a child, it's highly likely, or we'll say often is the word, but it is feared that many times they will develop hepatic fibrosis. Now, is hepatic fibrosis the same as cirrhosis? Well, it could be, but remember, cirrhosis is not only fibrosis, but it's nodule formation as well. So we're not saying cirrhosis, we're saying hepatic fibrosis in kids who survive the autosomal recessive polycystic childhood kidney diseases. Let's talk about cysts in the medulla. Wouldn't that be a more likely place for a cyst? Because that's where the collecting tubules are, okay? There's a condition which I've seen a couple of times. Radiologists will show a CT or ultrasound in which when you look at the kidney, here, maybe I should make this a little bit bigger. Do you see all these little holes in the pyramids? That's the medulla. And these little holes make it look like a sponge. And if they retain fluid on IVP or ultrasound, they call this a medullary sponge kidney, or MSK. Very often, it is not going to be producing renal failure. It's often an incidental finding. Okay, you can see it on CT, you can see it on ultrasound, and of course, you can see it very, very nicely here on a kidney that has been cut, that has MSK. Now, another type of medullary, or we'll say cortical medullary type cyst, is this disease. It's a hereditary disease. It's autosomal recessive, again, seen in kids. And I wish I could pronounce the name properly. I don't know if you can. But whenever I have like 4 or 5 consonants in a row, I start to fumble with my lips. Nephronophthistis, okay? And you have cysts at the cortical medullary junction. It's another hereditary disease. So autosomal recessive means it appears early in kids and it's progressive, and it is not an incidental finding like medullary sponge kidney. And it's not like medullary sponge kidney because the cysts, of course, they start out at the cortical medullary junction. Now in here, they are actually pretty big, so they extend well into the medulla. But this is nephronophthistis, okay? And I'm glad that last night I finally found like a really good picture of it. I had a hard time finding one before. So how about if we move on to the simpler, commoner type of cysts? Because none of these type of cysts you have probably seen, but if you've dissected elderly people, you may have seen the so-called acquired cysts. The most common type of reason for an acquired cyst are patients on dialysis, or we could say patients with any type of renal disease which require dialysis may have had some type of general disease which results in blockage. Could it be fibrosis? Could it be edema? Could it be crystals? Could it be blood? In which you're going to see these small cystic structures, okay? Now, that could be probably differentiated a little bit from what we always called the simple cysts. They appear in the cortex. They are also called retention cysts, and they are also acquired. Now, why would they be called a retention cyst? Because when you think about it, if fluid or urine drains through tubular structures, whether they're small or large tubules, if there's any reason for a blockage or an obstruction of a tubule, the cyst can occur prior to the blockage. Wouldn't that be logical? You got something that's obstructed, and therefore the pressure builds up before the obstruction results in a cyst, even at the fairly small tubular levels, okay? They are very, 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 very common. They're incidental, they're asymptomatic, and they are not hardly at all ever associated with renal failure. Okay, you know what? I think we've been doing a good job. So I think it's a little bit early to take our break, but let's get into the main topic that we're going to be talking about today. And that's glomerular diseases or glomerulopathies or glomerulonephropathies. Okay, and then we'll probably save tomorrow for tubular diseases, vessel diseases, obstructions, tumors, and so forth. But we're going to spend the rest of today talking about nothing but glomerular diseases. And this is where I warned you that they could be very, very complex. So I would say, please don't go crazy and try to remember every single thing about every single type of glomerulopathy, okay? But try to understand the big pictures of what happens. And I'll give you an introduction into it before we go into the, maybe 4, 5, or 6 technically different types of glomerular diseases, okay? So how about, if we talk about the proper terms first. Probably the best name is glomerulopathy. I've seen it called the glomerulonephropathy, of course, because it's part of the nephro or kidney. And because many of them are called glomerulonephritis, not all of them, but many of them, which you see some classical features of glomerular infiltration, some of which follow the general types of inflammatory lesions we've been talking about, and some of them which are kind of unique. I've also heard the term glomerulonephritis. But let's keep our sanity, and we just call them glomerular diseases or glomerulopathies. Now, here's the introduction before we get into the real heavy stuff. A patient with primary glomerular disease can manifest that disease in a variety of ways. Probably one of the most common ways is to develop what they call the acute or chronic nephrotic syndrome. Acute meaning it's significant and it occurs rapidly. Nephrotic syndrome may not occur rapidly and may be not acute. It could not only appear acutely, but it could progress very, very rapidly into death and renal failure, a rapidly progressive type of renal failure, or what they would call a rapidly progressive glomerulonephritis, or rapidly progressive glomerulonephropathy. Okay. It could also just progress very, very slowly and eventually produce chronic renal failure. Remember we said chronic renal failure could be the result of any long-standing or even a type of primary renal functional disease, or, especially in many of the kids and adults, it could persist as hematuria and proteinuria. And why would that be? Well, think about it. When you have problems with your glomeruli, the primary area of problem is the basement membrane. If that membrane is not intact and uniform and smooth, okay, it's going to leak blood and it's going to leak protein. And technically, there's even a kilodalton limit to the molecular weight of the molecule that can go through the glomerular basement membrane. So it could even leak larger molecules as well as proteins, which it normally would retain. Now, I'm going to be going through a whole bunch of the so-called primary glomerulonephropathies. But what are the pathologic manifestations in general? Okay, well, being an inflammatory process in many cases, you can have leukocyte infiltrations, you could have neutrophils, you could have macrophages, okay? In the so-called rapidly progressive one, you could have a collection of macrophages primarily called crescents, which accumulate at the periphery of the glomerulus usually, and that's usually a very, very, very serious problem. Probably the one thing that is present in most of the various glomerulonephropathies is you do not have a uniform basement membrane. It could be lumpy, it could be bumpy, it could be spiky, it could be thin, it could be thick, it could be denser than usual. Okay, but it's not a uniform, nice array of type 4 collagen and a few other supporting structural proteins like most basement membranes are. Now think about it. If a glomerulonephropathy is chronic, like all chronic diseases, they may end up with fibrosis, scarring, or what we would call hyalinization or sclerosis. So a chronic glomerulonephropathy, you may have many or most glomeruli which have no cellular detail. They're just like big scars, okay? Now, another general term I want to mention are the various pathogeneses. I guess I should make that a plural rather than a singular, shouldn't I? Because we're talking about multiple factors here. Why would you have a primary glomerular disease? Well, maybe you have antibodies against your glomerular basement membrane. Hey, do you remember when we were talking about good pasture syndrome, when we talked about lung? We said that in good pasture syndrome, you develop antibodies against your own basement membrane of the lung, but also of the kidney, because both of them have type 4 collagen. So that's one reason. Or let's say it's not an autoimmune type of thing, but let's say you have antigens there, cells, proteins, which shouldn't be there due to various reasons, and now you develop antibodies against planted or non-inherent antigens. Do you remember when we talked about immune diseases in general? And we said that there's 3 places in the body where antibody complexes just love to be trapped. We said one of them was synovium. We said one of them was endothelium. But the third one was glomerular basement membrane. So a glomerular basement membrane, or a glomerulus in general, is a magnet for circular antigen antibody complexes. Could you technically have antibodies against the various cells in your glomerulus, like the mesangial cells or the podocytes? Yes, that's another pathogenesis of some of the glomerulonephropathies. Could you have not only antibodies, but could you have a cell-mediated immunity? In other words, type 4 hypersensitivity, in which you are now having cells, T cells, cytotoxic T cells, also cells like in tuberculosis, where it's a direct cell-to-cell type of attack rather than antibodies. Okay, now I've never told you to memorize pictures before. Okay, but I'm going to show you a picture now that is very, very easy to memorize. Okay, because it's simple, and this is it. So I put down last night for the first time, please visually memorize this. First of all, you got a bunch of these little foot processes on the top, okay? And then on the endothelial, or the blood side, you can see part of a blood cell down here. So these are the fenestrations of the capillary endothelium. And fenestration means there's little holes in it where the basement membrane technically is not fully covered by endothelial cytoplasm. But here you have a density. This is an electron microscope. So the density of this is uniform. It's just as gray over here as it is over here, as it is over here, and it's just as thick over here as it is over here. So if you want to just remember that a basement membrane, and there's various proteins in it, but the main one, of course, the main structural protein is type 4 collagen, type 4. If you just want to remember that the basement membrane should be uniform in thickness and uniform in density. If you don't want to memorize the whole picture, I want you to remember that. Of course, you might say that the foot processes are kind of fenestrated all, only they don't call them fenestra, on this side of the basement membrane, on the urinary side. They call them filtration slits, okay? And this is what regulates what can or can't come into the urinary space from the vascular space. And here's a nice little diagram. This is an actual electron microscope, but this is a diagram. Podocytes on one side, endothelial cytoplasm called fenestra on the other side, but a uniform thickness and uniform density, type 4 collagen, basement membrane. Okay, now when we talk about the various glomerulonephropathies, many of them will be glomerulonephritis, which means that things that we've learned about the inflammatory process, of course, have to apply to the kidneys as well. So do you remember when we talked about inflammation, we talked about neutrophils being an acute type of cell, the monocytes perhaps not being not so acute, which of course are macrophages once they come out of the blood into the tissue. We talked about the role of T cells creating cytokines. We talked about natural killer cells. We talked about platelets and coagulation in general. Now in the kidney, of course, we got another type of cell, often regarded as an inflammatory cell because it proliferates in some of the glomerulonephropathies. And those are called the mesangial cells. The mesangial cells have kind of a phagocyte role or a macrophage kind of a role, but they also are somewhat contractile in that they can regulate the flow of blood throughout the glomerulus also. So these are your mediators. These are your cellular mediators on top. And I say they're usual because these are the same cellular mediators or cellular players we talked about in inflammation in general. But then don't forget, you also have your so-called cytokines, a whole wide variety of substances made by the cells, particularly the T cells and the macrophages, okay, and the chemokines, which are attractants for the leukocytes or neutrophils, as well as a whole wide variety of coagulation factors. So, I think that what I've given you is a pretty intense general introduction into the glomerulonephropathies. We're going to take our break now, and I want you to think about the last few things we talked about. And then we're going to come back and start talking about the actual various types of glomerulonephropathies or glomerulonephritis. And that's going to be the first one. It's also the most common one. It's also probably the easiest one to understand as well. So let's do a 3-song break. We'll see you in 10 minutes. And then we'll get into the real hot and heavy final, more or less, topic of glomerular diseases.
though the years are showing. Look at this life, I still don't know where it's going. I don't know much, but I know I love you. That may be all I need to know.
Look at these eyes, they never see what matters. Look at these dreams, so big and so bright.
I don't know much, but I know I love you. That may be all I need to know. So many questions, still left unanswered. So much I've never broken through.
And where I'm feeling nearly, sometimes I see so clearly. The only truth I've ever known is me and you.
Look at this man, so blessed with inspiration. Look at this soul, still searching for salvation. I don't know much, but I know I love you. And that may be all I need to know. Don't know much, but I know I love you. That may be all I need to know. I don't know much, but I know I love you. That may be all there is to know.
I guess I'm not supposed to talk with food in my mouth, but this is not really food, this is chocolate. One of the essential things of life, as well as coconut coffee. I don't think I had any big thoughts during the break, except one. I have always kind of feared the discussion of glomerulonephropathies. It was not only where I suspect that you are often overwhelmed, but I usually am too, because there's like a good number of them. Maybe we'll talk about 6 or 7, and they're related to so many other things. And they have a lot of similar features. But today I really feel like I've simplified about as much as I ever have. Maybe next year, if I'm still alive, I could even do a better job, but I feel very good about today. So let's continue on with the diseases of the glomerulus. The first one that's always mentioned, and probably the most common one, and I think the most logical one, is what they call acute glomerulonephritis. And by acute, it doesn't necessarily mean there's a lot of neutrophils there. It means it occurs acutely, okay? The old name for this, and it's still used, is called post-streptococcal because it generally follows, I'd like to say always, a strep infection, which means it's primarily in kids, and they get a strep infection, okay? And during the course of the strep infection, they develop antibodies against this type A strep, okay? The strep infection goes away, okay? But the antibodies not only persist, but they wind up attacking the glomerulus as well. And in the process of doing that, they accumulate immune globulin, primarily IgG, but sometimes IgM, and complement, what goes along in it, the destructive complement, along the glomerular basement membrane. And that complex causes the basement membrane to be non-uniform, sometimes focally thick, or what we call lumpy and bumpy. And when I was in medical school, we learned about post-streptococcal glomerulonephritis as being called lumpy bumpy glomerulonephritis. Okay, not that it's the only one. There are others which cause thickening or irregularity of the basement membrane. But because of the damage to the basement membrane, blood leaks through, okay, oliguria, okay, because of the inability to function properly. Azotemia can develop for the same reason. And basically, you could say it's a glomerular damage collection of immunoglobulins and hypercellular inflammatory cells. We increased in mesangial cells and endothelium, and it looks like it's hypercellular following a strep infection, usually a few weeks. And here's some pictures of it, okay? Well, we've seen a bunch of glomeruli already, but you know this one has a lot of inflammatory cells in it. Yeah, some neutrophils, a lot of mesangial cells, and the immune deposits, okay, I'm going to show you this picture first. The immune deposits are along the basement membrane here, and they look like they're on the urinary side. Take a look. This basement membrane is not uniform. There's a bump, a lump over there, a bump over there, a bump over there. Okay, and here's the endothelial cell. And here's probably the Bowman's capsule, because the capillaries, which this is often towards the periphery of the capsule. In the accumulation of these immunoglobulins in the infection, if you labeled a dye that was fluorescent against antibodies, the glomerulus might look like this. Normally, there should be no immune deposits in the glomerulus. So that's acute glomerulonephritis, or acute post-streptococcal, or, you know, I like to just call it lumpy bumpy, but I'm a pathologist, so I always do things differently. Here is a type of glomerulonephritis that is not unique, and it's not an entity unto itself, but technically it could follow any type of glomerulonephritis, which clinically is rapidly progressive. So if that any glomerulonephritis for some reason goes completely out of control, not only do you have inflammatory cells in the tuft of the glomerulus itself, but look, in this, against the wall of the Bowman's capsule, you have nothing but inflammatory cells, and they're primarily macrophages. But that means that this is very significant, and when I say rapidly progressive, it's often fatal. And the average time from a diagnosis of rapidly progressive, either clinically or pathologically, like you see here, generally speaking, the patients are dead within a few months. We'll say 3 months, I think, are the statistics. They also call rapidly progressive crescentic. Why? Because there are so many inflammatory cells here, not just limited to the glomerulus, but also accumulating all unto themselves at the edge, because the glomerulus is kind of bounded by the Bowman's membrane, or the what we call the visceral epithelial cell, that there's nothing but inflammation here. So these look like crescents. They look like little moons, don't they? And of course, you could have immune complexes in them. You could even have antibodies against the neutrophils and the antibodies against the glomerular basement membrane. But remember, it depends on what type of glomerulonephritis was present, which clinically and pathologically rapidly progressed. Okay? Now, let's jump into a syndrome which is seen in many of the glomerulonephropathies. And if we said the main damage, the main problem with the primary or secondary glomerulonephropathies was damage to the basement membrane, that means you're going to be leaking protein from the blood into the urine. So patients with this particular syndrome, called the nephrotic syndrome, basically have four features, and they're all very, very logical. They have massive proteinuria, and they usually starts about 3 grams a day, but it could get a lot worse, okay? And because of the protein, primarily albumin, being spilled out into the urine, they now have low albumin in the blood. That's logical. Because they have low albumin in the blood, they have a low oncotic pressure. And remember, that was one of the main causes for edema, is a reduced oncotic pressure in the vascular space. Now, if you have hypoalbuminemia and a low oncotic pressure, a normal compensatory mechanism is to increase the amount of lipids in the blood, okay? Because your albumin is not holding that fluid in, so the body makes lipids. So you have a lipidemia. That's not too cool either. But even some of those lipids spill out into the urine as well. So these are the four classical features of the nephrotic syndrome, and they have numerous causes, but you could say glomerulonephropathies in general, and specifically a type of glomerulonephropathy we'll be talking about next, which they call membranous, one in kids, which is minimal change but can also produce the nephrotic syndrome. Another type of glomerulonephropathy, which is common, called focal segmental, as well as secondary to other diseases. Many of the glomerulonephropathies and therefore nephrotic syndrome could be seen in the systemic autoimmune diseases like lupus rheumatoid. They're in diabetics. They're in patients with accumulation of amyloid. Could be very, very destructive to the glomerulus and therefore glomerular basement membrane, as well as some drugs as well. So let's talk about the number one cause of nephrotic syndrome, or one of them. This might not be the number one, but it's probably the most common that causes it. Membranous glomerulonephritis has been linked to non-steroidal anti-inflammatories. Okay, we're talking about aspirin here, folks. Gold treatments, a variety of tumors. Okay, lupus, hepatitis B, hepatitis C. Okay, other infections as well. This is a pretty big differential diagnosis, isn't it? But in it, there's, once again, a deposition of antigen-antibody complexes. And in most of the membranous glomerulonephritis, even with nephrotic syndrome, most of the membranous are relatively indolent, which means they don't progress too much or cause nephrotic syndrome or renal failure. But more than half of the patients will still have persistent proteinuria. And about 15% will go on to the nephrotic syndrome. And when you consider the incidence of membranous itself, that's a pretty large number. You see in this glomerulus here, it looks like it's thickened in general. Do you see these little spaces around the little holes, which are capillary loops, which seem thicker than usual? Well, guess what? not only is that a thickened basement membrane and non-uniform, it's not necessarily what we would call lumpy and bumpy, but it has these little jagged edges on it, like there and there and there. So we often refer to membranous in terms of electron microscopy as spiky. So whereas the acute glomerulonephritis we called lumpy bumpy, the membranous we called spiky, although in general it's pretty thick in general. You'd think that these are fluorescent antibodies against immune complexes. Yes, they are. That's why this looks so green. And once again, we could see not only thickenings of the basement membrane, but what they would call effaced foot processes as well. And the basement membrane itself is thicker than it should be. Okay, but it's not as lumpy, bumpy thick as the acute post-streptococcal. That's membranous. And remember, it's associated with a lot of things, isn't it? So let's talk about minimal change glomerulonephritis or minimal change glomerulonephropathy, either one. It's also called lipoid necrosis, okay? Nephrosis, I'm sorry. And it's without a doubt the most common cause of nephrotic syndrome in children. And I know somebody whose brother had this, okay? And in minimal change, you don't normally see as horrific changes like you see in the other two types of glomerulonephritis. But if you normally know that foot processes should be on the urinary side of the basement membrane, you can see here they're degenerated or what they call effaced, or they have a lot of vacuoles in them. See, here's the capillary side with the fenestrations, and here's the rather uniform basement membrane, but the foot processes are degenerated. The word that they like to use is effaced, and that can cause the nephrotic syndrome as well in kids. And it's generally not a lifelong process, but it could be very persistent even into adulthood. Now, here's another type of glomerular disease. We're not calling it a glomerulonephritis because you don't see much by way of active acute inflammation, but you do see fibrosis. Okay, you know, fibrosis or sclerosis, which is identified by the increased collagen in parts of this glomerulus, gives it the appropriate name of focal, because it's only part of the glomerulus, and it's segmental, just a segment, and it's not glomerulonephritis, but they call it glomerulosclerosis, because that's collagen deposition, that's fibrin, that's fibrosis, that's sclerosis. So it is focal, it is segmental, it is sclerotic focally, and it's related to a whole bunch of other things as well. HIV, one, probably the biggest one, the biggest cause of glomerular disease in AIDS patients, heroin abusers, sickle cell patients, okay? We said that in sickle cell you can cause focal infarcts and secondary fibrosis in the spleen. Well, guess what? Also in the glomerulus too. And for some reason I don't understand in patients that are have a pretty significant obesity as a risk factor too. So it's the most common cause of adult nephrotic syndrome. Okay. Here's another type of membrane of glomerulonephritis, and it's a true glomerulonephritis. There's increased cells, inflammatory cells. It's called membranoproliferative. And look at this. It also has a bunch of things that it's related to. But if it's not related to people with hepatitis or alpha-1 antitrypsin or AIDS or malignancies, then it's basically all by itself are called idiopathic. And you have alterations, abnormalities at the glomerular basement membrane, especially in the subendothelial part. You have infiltrations of leukocytes, including neutrophils, but the prominent, when they say proliferative, the prominent cell of proliferation is not the lymphocyte, not the macrophage, not the neutrophil, but the mesangial cells. So it is the primary glomerulonephropathy in which the mesangial cells are the most proliferating. Okay, now I know at this stage you're probably a little confused, so we're going to go into the easy ones now. I think the hardest part is over. Another type of nephropathy is called Buerger's disease. And the reason why I made that U in red is because it is not spelled Buerger. Remember, that was a vascular disease in smokers, but it's just Berger disease. And remember, we said that with acute post-strep, you could get deposits of IgG or IgM. Well, with Buerger's disease, the primary problem is immunoglobulin A deposits in these mesangial areas, which is more or less the more central part of the glomerulus. And because of it, there's problems in filtration, even at the basement membrane level. You can see these immune deposits on fluorescence, and therefore blood leaks through and proteins leak through. Now, I probably should have said this at the beginning, but I'll say it now. Most kidney or glomerular kidney diseases are not routinely diagnosed by regular pathologists. When a radiologist or renal physician, now it's probably mostly radiologist, does a needle biopsy of the kidney for glomerular diseases, these are usually sent to specialized labs that can do immunofluorescence or electron microscopy, which is not usually done at most hospitals, even the so-called big university hospitals. So, make it easy. IgA nephropathy, also called Buerger's disease, is IgA deposits in the mesangium, damage to the basement membrane so the blood and proteins leak through. Okay, now there are some hereditary glomerulonephropathies, which I'm going to briefly mention. One of them is called Alport syndrome. Okay, so an Alport syndrome is a defective glomerulus, specifically an inherited form of a disease in which your body does not, because of genetic reasons, make proper type 4 collagen. Remember, we said type 4 collagen was the primary constituent of the glomerular basement membrane. Well, it's defective. And do you remember when we talked about Goodpasture syndrome? We said that in Goodpasture syndrome, you have antibodies against type 4 collagen. Well, this is different, because when you have antibodies against type 4 collagen in Goodpasture syndrome, it's still normal type 4 collagen. But in hereditary Alport syndrome, it's a defective collagen, okay? And it's usually associated with hearing and eye disorders. So that's the tip-off. So if you have a child, okay, it's hereditary, with renal failure and both eye and ear problems, think of Alport syndrome. And if you did electron microscopy, you might find that there aren't immunoglobulins against the type 4 collagen. It's just a defective type 4 collagen. Another one that I've never seen, but they say it's pretty rare, is something called thin GBM. In other words, you have a uniform glomerular basement membrane. There's no deposits in it, but it's very much thinner than it should be. So remember, I said when you look at a basement membrane, it should be uniform in thickness and uniform in density. Well, these are probably uniform in thickness and uniform in density, but they're just thinner than they should be, okay? So that's another hereditary primary glomerular nephropathy resulting in thin glomerular basement membranes. Here's an easy concept to remember, and it's just called chronic glomerulonephritis. And it's not any different from the other glomerulonephritides that we talked about. With any type of glomerulonephritis, whether it's acute or membranous or focal sigma, blah, 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 if it progresses, can result in hyalinization of the entire glomerulus. Okay, so what happens when the glomeruli in the cortex are scarred? The cortex then become thin. And when we say they're hyalinized, we're talking about fibrosis. And what is fibrosis? It's the end stage of inflammation. So these can follow the various types of glomerulonephritises. Okay? A patient on dialysis might be seen with that had a history of long-standing glomerulonephritis, could actually be seen microscopically as having many, if not most, of the glomeruli that are actually hyalinized. I should have put a picture in there, but think of a glomerulus, and rather than seeing capillaries and foot processes and mesangia, so you see nothing but scar tissue. Wouldn't that be logical that a chronic glomerulonephritis, like a chronic any type of inflammation, would result perhaps ultimately in scars? Okay, so that's why you often see them in dialysis patients. I have a final slide for you, and we talked about many of the glomerulonephropathies or the glomerulopathies as being associated with diseases. But in general, many of the patients themselves with primary lupus or a type of platelet disorder, Hannock-Schönlein purpura, we said that can be associated with IgA nephropathy, patients with endocarditis, patients with kidney diseases, okay, often have a secondary glomerulonephropathy, and those are also called KW kidneys for Chemisteel-Wilson. That's why diabetes, or the so-called nephropathy of diabetes, is often described as a nodular glomerulosclerosis. And why is that? It's because of basically small vessel disease. Just like the neuropathy is related to small vessel disease. Just like the retinopathy is related to small vessel disease. Well, what happens if you have small vessels? You could cause a glomerulosclerosis renal as well. Amyloid can accumulate in the kidney. It can accumulate in the glomeruli preferentially, or you can see basically kidneys when you cut them almost cut like pure wax, okay? Because much of the kidney itself is just loaded with amyloid due to chronic buildup of immune protein. We talked about Goodpasture syndrome, and we differentiated from Alport syndrome, because in Goodpasture syndrome, you might have normal type 4 collagen, but you're making antibodies against it, okay? That's an autoimmune disease. You're also making antibodies against your type 4 collagen in your lung, and that's why Goodpasture syndrome is classically described as hemoptysis and renal failure. Small vessels. Most of the people with Wegener's granulomatosis, which is primarily a disease of the upper and lower respiratory tract, die because of glomerulonephropathies, okay? And of course, multiple myeloma, with or without amyloidosis, although they're very closely related. can be regarded as causing a secondary glomerulonephropathies as well. Now, some of this list here are things that I just mentioned, but if you remember, some of the specific types of glomerulonephropathies had lupus and amyloid as, you know, one of the causative or at least risk factors. Okay, well, you know, we said a bunch today. And I can remember once I gave this lecture at one of the Caribbean schools, I forget, I think it was in St. Kitts, and basically I knew that it was a lot to throw at the kids. They went to the dean and they complained that Dr. Minarsik was being too complex. I hope that over the years I have made it a little more understandable, and I feel that today, even though I threw a bunch of stuff at you, that you can kind of remember the main points. So, does that mean we're done? Yeah, we're done a little bit early, and that's okay. So how about if we play our closing song and take our final sip of coconut coffee, and we'll see you in 5 days, which will be a new year. Somebody asked the question, will you continue this course into 2022? I will definitely continue this course into 2022. In fact, we're only about half done. So usually the course ends like somewhere in March or April or something like that. But we're going to be spending almost the entire month on the biggest topic of the genitourinary system. So let's see who we're going to have entertain us for the closing song.
Stay awake just to hear you breathing. Watch you smile while you are sleeping, while you're far away and dreaming. I could spend my life in this sweet surrender. I could stay lost in this moment forever. Every moment spent with you is a moment I'll treasure.
Rock on, buzzards. And remember, when it comes to learning how to be what you have always dreamed to be, you don't want to miss a thing. So, rock on, buzzards.